Extract 1. Questions 1 to 12. You hear an emergency doctor talking to a patient called Penny Rawford. For questions 1 to 12, complete the notes with a word or short phrase. Mrs. Rawford? So, I understand you've been brought in here because you fainted at work.
That's right.
Can you tell me a bit about it?
Well, I can't really remember much. I was sitting at my desk and I suddenly got this really awful headache. My head felt like someone had fired a bullet into it. I've never had anything like it. I mean, I've had headaches before, but nothing serious. And this one was different because it was just in one place in my forehead here. And I can't remember what happened then, but my colleague sitting at the next desk, she saw me and she says I collapsed onto my desk. So she came over to help, but she says she couldn't wake me up and I was out for quite a few minutes. But I wasn't still. She says I was jerking, but I can't remember any of it. Apparently they called an ambulance, and I do remember the paramedics arriving, and I was able to answer some of their questions, even though I was still feeling a bit groggy. They asked me if I'd had any sort of trauma before I fainted, but I hadn't. I'd woken up as normal and cycled into work, nothing unusual. Oh, and they also wanted to know if I'd taken any recreational drugs, but I wouldn't ever touch anything like that. I don't even drink alcohol, but they did ask me if I'd had any incontinence when I was unconscious, and I found that I'd leaked a bit of urine. I was ever so embarrassed, but they were quite okay about it. I suppose they're used to it. And once they'd got me into the ambulance, I felt really awful. I had this nausea, but they gave me something for it. It's not so bad now.
Oh, that's good. So, how's your health been generally in the past? Have you ever had anything like this before?
No, not really. I did go to the doctor a few years ago when I had some stomach pains. They did an endoscopy, but everything was normal and I've been fine since then. I'm usually quite healthy, all my family are. I've only ever had one operation, and that was a few years back now, in 2014. It was just after I'd had my third child. I had to have a hysterectomy, but I've been fine since then. There was something about a year later. It must have been 2015. I'd been putting on a bit of weight and I thought it was because of the operation, but I've been feeling a bit tired as well and getting these cramps at night. The doctors did some tests because they thought I might have an underactive thyroid, but it was okay. I think maybe I'd just been overdoing it a bit.
Oh, that's excellent. Well, how do you feel now? It looks as if you've got a bit of bruising there on your face.
Yes, and I think I've got a cut there too, a little one under my eye. That must be where I fell on my desk. I've still got a bit of a headache, but nothing like as bad as it was. I do feel as if my neck's a little stiff, but that might be because I've been lying down. And the paramedics asked me lots of questions to see if I had anything funny with my vision, but that's all okay.
Great. So now I'd like...
Extract 2, questions 13 to 24. You hear a physician talking to a patient called Mrs. Gregorius. For questions 13 to 24, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes. Good morning, Mrs. Gregorius. Be seated. Tell me what your problem is.
Good morning, doctor. I'm having severe abdominal pain and nausea after eating.
What's your age?
38, doctor. I'm intolerant to fatty foods and my urine is dark colored.
Do you get fever?
Yes, I get chills and low-grade fever, nausea, and a sharp stabbing pain in my abdomen. But when I lie down on my right side, I feel somewhat relieved.
How long have you been suffering with these problems?
For the past 3 months, doctor.
Have you had any surgery before or any diseases?
No, doctor.
Are you taking any medications?
No, doctor.
Are you allergic to any medicine?
No.
Do you smoke or drink?
I do smoke 1 pack a day, but I never drink.
Do any of your family members have a history of any diseases?
No, doctor.
Tell me something about your family background.
I am married and living with my husband and 2 children.
Do you have any symptoms of seizures and ataxia?
Yes, doctor, I have.
Well, your MRI report is positive for cholelithiasis without CVD obstruction. Laboratory studies show that you have elevated bilirubin and elevated white blood cells. Your heart rate and rhythm is regular without any murmur or gallop. Bowel sounds are of a high pitch. Lower extremities are normal in color, touch, and temperature. No ischemic changes are noted. Range of motion is normal. You have developed gallbladder disease. I would suggest laparoscopic cholecystectomy with intraoperative cholangiogram.
Okay, doctor.
Part B. In this part of the test, you will hear 6 different extracts. In each extract, you will hear people talking in a different healthcare environment. For questions from 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now look at question number 25. Question 25, you hear 2 doctors having a discussion about chemotherapy for bladder cancer. Now read the question.
Doctor, could chemotherapy inside the bladder reduce recurrence of cancer?
According to a recent study, patients who had the chemotherapy drug gemcitabine placed inside their bladder following the resection of the tumor had fewer recurrences. Out of more than 400 subjects, 384 completed the trials and were included in the study, which randomized them to receive the chemotherapy drug called gemcitabine. To treat the bladder cancer, they implanted it into the bladder and let it settle there for an hour, and the other group with saline without gemcitabine in it. They kept the patients under observance for every 3 months for 2 years. Thereafter, every 6 months for another couple of years. What they observed was the recurrence were 34% less. The purpose of this study was to prevent bladder cancer from invading the muscle wall of the organ. Moreover, this is a very simple method without any significant side effects. Question 27. You hear two doctors discussing occupational therapy for improving visual function. Now read the question.
Doctor, can visual function be improved through occupational therapy?
Well, findings proved that occupational therapy for patients with poor vision performed at their home and directed particularly toward helping them with both meaningful and challenging tasks, helped avoiding depression that actually improved the visual function as well. It was observed that those with milder visual impairment actually performed much better on these questionnaires after the occupational therapy group, whereas those who were in the supportive therapy attention control group could not improve their visual function measures. Therefore, the occupational therapy role not only improved in some of these depressive symptoms, but also in this specific subset of patients with mild impairment did improve their visual function as well. The comprehensive approach to rehabilitation, including in-home occupational therapy for those with visual impairment, is the key to improving visual function. Question 28. You hear two doctors talking about why primary doctors should not perform eye screening. Now read the question.
Doctor, why shouldn't the primary care doctor perform eye screening of the patients?
Well, according to the recent recommendations of the United States Preventive Service Task Force, the primary care doctor shouldn't include a vision screening to the list of primary tests for his patient in his office. To know why vision screenings may not trace out the precise vision impairment, we need to look at the factors that can restrict the effectiveness of the results. Many vision screenings are performed only for distance visual acuity, and it does not give any indication of how well the eyes work together or focus up close. It also does not give any detail about the eye health. Although certain screenings may include a plus lens test for farsightedness and eye coordination tests, even these screenings will often fail to detect many vision defectiveness. Often, a vision screening is conducted by primary doctors or administrative personnel who have little training, who haven't the complete knowledge to assess screening results. Even if the screenings are performed in pediatricians' or primary care physician's office, the scope of vision screening may be restricted by the type of lab equipment. Question 29. You hear two doctors discussing dysphagia after the use of breathing tubes in ICU patients. Now read the question.
Hello, doctor. Is trouble with swallowing common following use of breathing tube?
Breathing tubes are meant to save lives, and they are often used for critically ill patients as well as during various surgeries. However, using breathing tubes has a side effect of difficulty in swallowing called dysphagia. In the ICU, patients had breathing tubes down their throat, typically more than 48 hours, will have a minor difficulty of swallowing and some voice problem as the tube is pulled. If it becomes worse, it can last years afterwards. According to the findings, most patients in this 5-year study recovered from their dysphagia within 6 months. However, There are also cases of the condition lasting up to 5 years. The good news is that even in patients with the prolonged periods of dysphagia, ultimately they did recover some function. Question 30. You hear two doctors talking about risk factors for kidney donors. Now read the question.
Doctor, how risky is donating one of our kidneys?
Well, there is an online risk tool to calculate the long-term risk of end-stage renal disease in people who are willing to offer kidney donation. This tool includes many characteristics in contrary to single characteristics used earlier. This multitude of characteristics help develop a comprehensive picture of risk in donating a kidney. This tool incorporates 10 different characteristics that are specific to the person willing to be a donor and provides an estimation of the absolute risk of end-stage renal disease over a certain period of time, say 15 years.
Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You hear a presentation by a specialist cancer nurse called Sandra Morton, who's talking about her work with prostate cancer patients, including a man called Harry. You now have 90 seconds to read questions 31 to 36.
My name's Sandra Morton and I'm a specialist cancer nurse, helping cancer patients deal with their diagnosis and treatment. I'd like to tell you about the type of work I do, and particularly about one of my patients, recently diagnosed with prostate cancer. Let's call him Harry, to illustrate the sort of things I get involved with. Now, before we get on to Harry, I'll give you a bit of background. Clearly, my job covers many aspects of patient care, but what's the priority? Firstly, prostate cancer is in fact the most common cancer in men in the UK, with over 40,000 new cases diagnosed every year. That's a staggering number. One problem is that this type of cancer actually develops very slowly, so there may be absolutely no sign that you have it for years. So, if we're going to reduce the number of cases, it's vital that people like me get the word out to as many men as possible, that we tell them how to spot the signs of prostate cancer, like an increased need to urinate or straining while urinating. Unfortunately, the cancer can be at an advanced stage by the time patients come in for tests, at which point the available treatments are far less effective. So, let me tell you a bit more about my patient Harry. Like many middle-aged men, Harry was offered a routine health check at his local doctor's surgery. As far as he was concerned, he had no particular health problems or obvious symptoms at the time, and so he almost ignored the invitation. But he'd promised his family he'd look after himself. His wife had died of ovarian cancer some years before, so he felt obliged to go. It was during his appointment that, based on a few symptoms he mentioned, Harry's doctor decided that he'd need further investigation for prostate cancer, and referred him to a specialist clinic at the hospital. Harry's trip to the clinic started with a routine blood test, which initially showed a slightly low hemoglobin level. A further test then revealed that his PSA, the prostate-specific antigen, was high at 20. He then saw a urology consultant who conducted a digital rectal examination and biopsy, a procedure that I always try to explain to patients may be uncomfortable but is entirely necessary. In fact, though, Harry said the 3-week interval between having a biopsy taken and hearing the outcome was far more of an ordeal. Harry told me that when he went to see the consultant to get his results, he immediately sensed he was in trouble. Although the consultant was very considerate in delivering the news, unfortunately the indications were that Harry did indeed have prostate cancer. He was assured that the cancer was low-grade and not aggressive. Harry had suspected the worst, and though he'd tried to prepare himself for it by doing some online research, finally hearing that confirmation was still a shock. In fact, the very mention of the word sent Harry into panic, which was very unlike him. So at the time I first met him, he was very vulnerable and grateful to have someone to talk to. Of course, the response to the illness amongst prostate cancer patients like Harry can vary enormously. I've dealt with some men, for example, who haven't really realised the importance of keeping up their medication because they've felt relatively well, especially if they've been experiencing unwanted side effects. Unfortunately, though, any break gives the disease the perfect opportunity to spread into the bones, making it much more difficult to treat and a successful outcome less likely. And some treatments do cause some unfortunate effects, such as erectile dysfunction, which some men really feel uncomfortable discussing, because it's a sensitive issue. Other patients have mentioned that even though they've been given a lot of help, it's still difficult to weigh up the pros and cons of the various treatment options they're offered, from ultrasound or radiotherapy right through to radical prostatectomy. So responses like these need to be taken into account by specialist nurses when talking to patients. For me, these factors really underline the importance of the community follow-up clinics we have in my area, which address many of these issues in the provision of healthcare for cancer patients. Staff at these clinics see patients during their recovery and only send them back to hospital for treatment if they develop significant new symptoms. Seeing patients in the clinics means that staff get to know each patient and build a relationship with them, which enables nurses like me to dispense advice and answer questions. And although we have no firm evidence, staff feel that's far more beneficial to patients than attending a large hospital clinic. So we're hoping more clinics like these can become available.
Now turn over and look at Extract 2. Extract 2, questions 37 to 42. You hear a presentation in which a researcher called Dr. Milan Petricevic is talking about the relationship between new technology and medicine in the future. You now have 90 seconds to read questions 37 to 42. Hi, I'm Dr. Milan Petricevic, and today I'd like to talk about the future of medicine, particularly in relation to the current technological revolution. To many of us, it seems inevitable that medical robots, automation, and artificial intelligence will replace many jobs in healthcare. Surgical robots are becoming increasingly more precise, and right now, man-sized robots can lift and move patients and transport them throughout a hospital. Silicon Valley investor Vinod Khosla once said technology would replace 80% of doctors because machines will be more accurate, objective, and cheaper than the average doctor. He added that eventually we won't need doctors at all. However, I disagree. Instead, I think technology in some specialties will finally allow doctors to focus on what makes them good physicians, treating patients and innovating, while automation does the repetitive part of the work. So let's look at some examples of how different areas of medicine will benefit from current technological advances. Take general practitioners as an example. Many doctors choose this specialty today because they have a chance to make a long-term impact on someone's life. And it's true that GPs enjoy tremendous trust from their patients. But seeing someone only when they are sick makes it hard to prevent disease and ensure someone's long-term well-being. It's even harder to do this when waiting rooms are overflowing and you only have 15 minutes to diagnose the illness, design a therapy, and offer health advice. In the future, wearable sensors and devices that stream data to a doctor's smartphone will notify them whenever vital signs are acting up and provide them with all the data they need wherever they are. These devices will also ensure doctors only treat patients who really need professional care, making it possible to offer simple treatment advice remotely. In turn, this will increase the time GPs have to treat and advise each patient, building trust and ensuring patients act on a doctor's advice. What's more, smart algorithms will allow GPs to tap expert advice on their patients' conditions and act as a gatekeeper, connecting patients to other specialties. And these are just a few examples. So what about radiology? Well, already IBM's medical sieve shows how artificial intelligence algorithms can scan hundreds of radiology images in seconds, doing the repetitive job of finding malignant or out-of-place phenomenon that currently radiologists have to do daily. This technology won't replace this important specialty. Instead, radiologists will have time to supervise how the algorithm is doing, or to research and innovate, making the technology behind these devices even better. Their time will be much more productive, rather than spent checking hundreds of x-rays a day. Ophthalmology will bring science fiction technologies to patients in the near future. Retinal implants might give vision back to those who have lost it, or even give humans supervision, augmenting what we can already do. In sports medicine and rehabilitation, the first forms of activity records from tech like Fitbits all focused on people who exercised regularly, but only provided basic insight into how they were performing. Now, a new generation of devices tailored to professional athletes is hitting the market, with apps providing detailed insights into movement patterns and force output in any movement. Sports medicine physicians will have concrete data to measure how athletes are improving. By the time these reach the mainstream public, sophisticated algorithms will be ready to analyze data from these devices and provide personalized suggestions to improve performance and to speed up recovery. Similarly, video consoles from Xbox to Microsoft Kinect will offer a way of monitoring how a patient is doing from a distance by seeing their progress liquidly on a screen. In oncology, this specialty will pave the way for personalized medicine. Even now, oncologists customize therapies to a patient's genetic background and their tumor's molecular makeup. Cheaper genome sequencing and measuring blood biomarkers are speeding up this process, with companies like Grail working on fluid biopsies which could filter tumor cells from blood samples. Tumors could soon be diagnosed earlier and analyzed without costly surgery. What's more, artificial intelligence could soon be used to help oncologists understand and even cure cancer. Already, IBM Watson obtains all the relevant information from millions of studies about a patient's case and makes suggestions for treatment plans most likely to work. In the meantime, patients are better informed about the disease thanks to social media communities of fellow patients. These signs all point to a bright future for oncology in partnership with new tech innovations. So what does this all point to? Well, my conclusion would be that, all in all, many jobs will be taken over by robots and automation in the coming years, but at the same time, amazing opportunities will also emerge, especially in medicine. These will require physicians to acquire new skills and improve their existing ones. In my opinion, the majority of specialties will have more time for patients and better insight into disease.